Hello, I'm Christopher Hirose. I'm an orthopedic surgeon here at the Coughlin Clinic in Boise, Idaho. And today I'd like to talk about a topic of Pescavis deformities. The Pescavis deformity is a deformity in which people have a high arch, and we see this very frequently in our clinic. This is an example of someone who has an extremely high arch, and the definition of such a deformity is an arch that fails to flatten when someone tries to put weight on it. So this is an example of a foot that has a normal arch, and if you're to look at it from the side, if you draw a line from the first metatarsal to this bone called the talus, the bone should lie collinearly along this line. But a deformity with a cavus foot, the bones are often above that linear line. We often see feet with an increased calcaneal pitch. And if you look at people from the back, they often have what we call a hindfoot varus deformity, such as this person. You could see this broken line. The heel bone is angled inward when it should be normally angled outward. Another characteristic is this plantar flex first ray. And so if you look at someone from the side like this x-ray here, you could see that collinear line is broken and the apex is dorsal. If you look at someone from the front, you could see that it's their big toe that's actually plantarly directed downward. And that's the structure that gives people a high arch. And if we look at people from the front and from the top, the toes often are angled inward. We call this a forefoot adductus deformity. So this person on the left-hand side, their foot is adducted toward the midline, whereas their right foot is straighter. If you get an x-ray, you could see that a broken line forms between the metatarsals and the long axis of the talus, like you see on your right. And then we'll often get what we call a Harris mat imprint. And so on your left-hand side, that's someone with a flat foot, and you could see a lot of the pressure of the arch is down on the floor. And on the right side, that's someone with a cavus foot deformity who has a high arch, and their skin of their arch does not contact the ground, but there's a lot of pressure underneath the ball of the foot and on the heel. Now, about 1 out of 10 people will have a cavus foot deformity. But in our clinic, we happen to see the vast majority of these sorts of problems because this is our area of expertise. Here's someone who came into clinic, and you could see that they're walking on the lateral border of their foot. Perhaps one of the most obvious forms of a cavus deformity is someone who's born with a club foot. And so as you see here, if this person weren't treated, then they'd be walking literally on the tops of their feet because the deformity is so severe. Now, a lot of times when babies are treated with clubfoot deformities, when they reach adulthood, they still have some residual clubfoot deformity, and we see that as a cavus foot deformity. Next, we notice that most people who have some kind of neuromuscular disease, and that includes people who have had a stroke, can often get this high arch foot, which becomes symptomatic. So you see in this picture, the left foot is clearly high arch. That arch is not touching the ground with weight bearing. And then the x-rays show the same deformity. And you can see the skeleton with the high arch here. Now lastly, about 20% of people, there's really no known medical cause of why they have a high arch. About 50% of the people who come to clinic with a high arch carry a diagnosis of a Charcot-Marie tooth disease. And that's about half the people out there. Now what that is Charcot-Marie tooth disease is a genetic defect with the protein that forms a myelin sheath around our nerves. So myelin is important for nerve conduction. If you don't have myelin, your nerves won't transmit impulses with the speed that they normally do. And so these people have some kind of defect where the nerve impulses aren't traveling down their leg quite as quickly. That turns out as a cavus foot deformity. You could also see people with muscular dystrophy, and I often think of Jerry Lewis, Jerry's kids with muscular dystrophy. What muscular dystrophy is a defect in the genes that make up muscle cells. And so you could see in this image on the left-hand side, that's someone with a normal biceps. And then in a generation before ours, people would have poliomyelitis, and that was often a extremely debilitating disease with people with lower extremity weakness, and a lot of people would have to be in an iron lung. But because polio affected the nerves, someone who has survived that often has a high arch foot. And then lastly, cerebral palsy or spinal cord tumors can also cause a high arch foot. Now, the cause of Pescavis went unknown for quite some time, but it was 1867 that Duchenne postulated that the deformity is a result of muscular imbalance. So what we know now today is that the muscles that connect the foot and direct the posture of the foot are imbalanced with some kind of neurologic injury. And so we'll often see this muscle called the Perineus Longus, that's this green tendon here, which goes underneath the foot. This muscle tendon unit overpowers the one on the opposite side. And so that will often depress the first ray to get a high arch. The second thing that we've discovered is that the posterior tibial tendon, as shown by this red cord, the muscle unit will overpower the shorter of the two tendons on the outside, the Perineus brevis. So what that will do is it will pull the foot inward toward the midline. So that will accentuate a high arch. And so on a real foot, what it's doing is it's pulling the foot this way. From the side, it's accentuating the arch. Now, in reality, what we see in clinic is a spectrum of deformity. We'll see some people with a mild Cavus deformity, and sometimes we'll see people with a very severe Cavus deformity. What we see clinically is that people will have pain on the lateral part of their foot because that's where they're putting most of their weight. We'll often see calluses on the ball of the foot because that's where a lot of pressure is forming. We'll see pain in that same region too, which we call metatarsalgia. And then sometimes we'll see people with instability of their ankle. As you see with this person, their ankle is very loose because the lateral ankle ligaments have ruptured. That can be the perineal tendons. These green tendons that you see right here are often torn with some of the Varus foot deformity. And also the lateral ankle ligaments may be ruptured, leading to ankle instability. The goals of treatment are always to create a better walking environment, and our goal is to have people ambulate with diminished pain and preferably without significant pain. What people need to know, though, is once you have a Varus foot, you will never ever quite have a normal foot because Varus feet tend to be stiff. And even with surgery, although oftentimes we can improve function, sometimes the stiffness remains. We usually always start off with conservative treatment in the form of an orthotic, like you see here. And sometimes that has to be a custom orthotic built to match the contour of the bottom of your foot. Oftentimes we'll prescribe shoes that are called extra depth shoes to accommodate claw toe deformities that we commonly see with Varus foot deformities. And sometimes we'll even add what's called a lateral flare to the wedge of the sole to prevent ankle instability and inversion injuries. Sometimes we have to move to one called an Arizona AFO, like you see here, which is custom molded to our patient's foot, and it's often much more comfortable than an off-the-shelf AFO. Now, when people fail conservative treatment, and if they're candidates for surgery, that's the time that we consider operative intervention. Someone who has poor blood flow, or someone who has multiple medical problems that would preclude a good result surgically. As long as someone seems to be a reasonable candidate for surgery, that's when we talk about surgery to improve function and pain after we've failed conservative treatment. Our goal is what we call a plantigrade foot, and this is something that we try to achieve. And a plantigrade foot is a foot where the heel strikes the ground and the toes are striking the ground. So that includes human beings. The way we walk, our heel strikes the ground and our toes strike the ground. If you contrast that with a digitigrade foot, that's someone who walks on their toes all the time, and a lot of people with a tight heel cord will walk on their toes. So an example of that is a dog or a cat. Dogs and cats actually walk on their toes and their heel never hits the ground. Now, with surgical treatment, this is a combination of soft tissue procedures and bony procedures. And there's not one procedure that fits everybody. This is a tailored procedure to get your foot lined up correctly. Now, with people who are severely deformed and have rigid deformities, this is when we turn to what we call a triple hindfoot arthrodesis. And with this method, we're getting the bones of the hindfoot to grow together in the proper position. When someone undergoes this, they require multiple screws, as you see here. The results of surgical correction depend on the procedure that was performed. A variety of procedures are utilized, and there's no one cookbook answer for all of the people who have cavovarus foot deformities. Our goal is to have an increased level of function and a decreased level of pain. We take foot and ankle issues very seriously here at the Coughlin Clinic. And I feel very strongly, as my father did, that it's important to shop around, to be treated with a surgical team that you feel comfortable with. It never hurts to get several opinions if you're uncertain in terms of the direction that you've been told. Thank you.